So I'd like to welcome everybody back, and the next session will be moderated by Yulia Ogorova, who is has been working with DASH since its inception practically, and she's a doctoral student, and we're really grateful. She's also been very involved in our experimental medicine, health data science course, and we owe a lot to her. So I'm going to hand it over to Yulia to facilitate this next session, and we look forward to the trainee presentations. Thank you.
Thank you, Anita. So I'd like to first of all welcome everybody and thank you for joining the sessions today. And for this particular session, we have received a handful of abstract submissions. But today we would like to present you with 4 very exceptional presenters that I will introduce just a little bit later. So today presenters will be competing for the Data Science and Health Trainee Research Award with $500 prize for the winner and $200 prize for the runner-up. And before we proceed, I would like to introduce you to 3 adjudicators who are going to judge the presentations. So first one is Dr. Anita Palepo, who is the head department of the medicine and the DASH colleague. The second one is Teresa Singh, the director of the VGH and UBCI Echo Core Lab and the DASH colleague. And the third one is Anna Meredith, the research manager for the UBC Department of Manager and the DASH cluster. So what we're going to do today is each presenter will have 10 minutes to present their research related around AI and medicine. And then we will leave 5 minutes for Q&A session. So if you have any question, meantime, you can post them in the chat or just raise your hand and I will ask you to unmute and ask your question. During the Q&A, the priority first will be given to the adjudicator committee to ask their questions first, and then I will open the questions for everyone in the audience. So to start with, I would like to present our first presenter, which is Dalina Dadani. She's a PhD student in the bioinformatics program under the Department of the Obstetrics and Gynecology, supervised by Dr. Aline Talhouk. And the title of the presentation is Assessing the Reproducibility Crisis in Vaginal Microbiome Studies for Clinical Application and Endometrial Cancer. So then you can go ahead and share your screen.
Thank you. Can you see my screen?
That's all perfect.
Thank you. Hi, everyone. My name is Dalina, and I am a PhD student in the Uterine Health Research Lab at VGH. And today I'll be discussing some of our work where we assess the reproducibility crisis in vaginal microbiome studies for clinical applications in endometrial cancer. So for a little bit of biological context or the problem that we're trying to solve, for the longest time, the uterus was considered to be a sterile environment, but studies have not only confirmed the presence of bacteria, fungi, and yeast in the uterus, but also associated it with diseases such as endometriosis, hyperplasia, and endometrial cancer. Endometrial cancer, or EC, is the most common gynecological malignancy here in Canada. But unfortunately, there are no general screening techniques available, and we are relying on biopsies for diagnosis. Biopsies are extremely painful and invasive, and we don't want people to go through them unnecessarily. So several studies have identified a vaginal microbiome signature for endometrial cancer, but none of them have translated to the clinic yet. And this is because the microbiome studies are facing a reproducibility crisis, which is caused by a variety of factors as shown in the image on the slide. But the ones that I want to highlight today are incomplete methodology reported by authors, unavailability of metadata in published studies, and the healthy microbiome is dependent on factors such as age, BMI, and ethnicity, and authors need to account for these in their analysis. The one that I'm going to highlight throughout the presentation today is lack of method standardization, where different data science pipelines and bioinformatic pipelines are leading to biologically different conclusions. And this is a major problem if you want to take something out of research to a clinical setting. So before we get to methods of my project, I wanted to give you a brief overview of what a data science pipeline looks like for the vaginal microbiome data. We start with sample collection, and we will sequence these biological specimens using a sequencer to generate some sort of reads. And then the reads will undergo quality filtering, where we keep the most top quality filtered reads, resulting in a sequence space that looks like this in the bubble here. And then you can take one of the two routes. You can either cluster these reads based on similarity as shown in the bubble on the top, or you can use most of sophisticated machine learning algorithms to denoise the data even further and keep only the most top quality reads or true biological sequences, as we call them in the field. So our objective with this project was to evaluate vaginal microbiome studies that report a signature for endometrial cancer. And we wanted to evaluate them for three things: reproducibility and replicability of their data science pipelines. And then we wanted to test a state-of-the-art pipeline for improvement, because bioinformatics and data science is ever evolving and there's always room for improvement. And then we wanted to test all these pipelines or analytical pipelines for their implications on downstream models. So for our project, we defined reproducibility, where we're using the same data and same analysis pipeline as the authors. And replicability was defined as using a different data set, an independent data set with the same analytical pipeline to reach the same conclusions. So using a literature search, we identified 5 studies that report a vaginal microbiome signature for EC, and we implemented each of their computational pipelines on all the 5 cohorts. So the table here shows the 5 data sets that we found, the pipeline they used, and whether they went down the clustering or the denoising route. And our lab is down here in the red, where we're trying to use a state-of-the-art pipeline which combines denoising and clustering to see if it has any sort of improvement on reproducibility and replicability of downstream models. We use metrics such as alpha diversity, beta diversity, differentially expressed taxa, and inter and intra-study replicability, which I'll be defining in the following slides. So alpha diversity is a measure of diversity within a local community. So it's either within EC or within benign. And from literature, we know that benign has a low diversity, where the uterus is mostly dominated with one species known as the lactobacillus. And when in a malignant state or anything that's not normal, rarer taxa become more prevalent and the lactobacillus amount decreases. Beta diversity is a measure of similarity between two communities, so between EC and benign, and it is based on ecological distance. So in a data science point of view, this is basically a PCA, which is accompanied by ANOVA to measure the influence or the percentage of variance explained by clinical covariates such as histology, vaginal pH, BMI, and ethnicity. So for results for the alpha diversity, the plot here shows each of the 5 pipelines that we implemented on all the 5 cohorts on the x-axis. And the trend that we're looking for is that the red box plot is higher than the green. The red stands for EC, the green is a benign condition or a normal condition, and we are hoping to see that EC has a higher diversity compared to benign. So what we found that all studies are reproducible, but not all are replicable. So for example, if you take the Antonio Walsh pipeline on their own data set, on the Antonio data set, you'll see the right trend where the red box plot is higher than the red. But when you take the same pipeline on an independently curated data set, such as the Menzi, you'll observe the reverse trend, which is quite problematic to come to a clinical setting. Our pipeline, which is all the way at the end over here, you see the correct trend no matter which data set you process it with. So all data sets show the correct trend, which shows that it is more consistent and more stable compared to the other pipelines. And the only thing that different that this pipeline is doing is combining denoising and clustering techniques. For beta diversity, we see a similar plot here where each vertical box is one of the pipelines we tested on the cohorts shown on the x-axis. And on each row is a clinical covariate that the authors reported. One thing I want to point out in this plot here is that not all studies report all clinical covariates, which is already problematic. There is no consensus on which covariate to report on. But what we found across all pipelines and data sets is that histology alone explains less than 10% of variance in these data sets. And individualistic factors such as age, vaginal pH, and BMI have a stronger influence on microbiome communities and must be accounted for in analysis. And as we can see, not all do that. Our third aim was to identify specific strains of bacteria that are connected or associated with EC. And unfortunately, we weren't able to reproduce or replicate results from any of the 5 studies. And I'm not going to try to pronounce these strains of bacteria, but our pipeline was able to replicate results from only one study, which is, again, very problematic to replicate results only from one study. And our analysis found that Streptococcus could be a potential biomarker for endometrial cancer, which is over here. We see that it's highly expressed in 3 of the 5 studies. But in one study, we observed the reverse trend, which is again problematic, and this needs further investigation. Our last aim was to use machine learning to evaluate inter and intra-lab replicability. And the point here was not to come up with the best model that could be employed clinically for distinguishing EC from benign, but what we wanted to do was learn distinctions between EC and benign based on data from one lab and see whether the same distinctions hold on data sets produced by other labs. And we did this using boosted tree classifiers and area under the curve as the performance metric. So the plot here, we have the AUC on the y-axis, and each point is one of the models that we trained on the cohort as shown on the x-axis, and every vertical box is the data set that the model was tested on. So there were 2 different types of tests we did here, inter and intra-lab replicability, and the triangles are within lab. So can we improve replicability within a single lab? Our pipeline is represented by the purple color on the plot, and we see that it is more consistent compared to the other pipelines. You'll see less fluctuation compared to other pipelines, and it almost in every case it improves the within lab replicability, where you see that the purple triangle is higher than the counterpart, except for this one case here. So combining the denoising and clustering techniques are generally more consistent and improves replicability within and across labs. Some key takeaways include that clustering and denoising together is more stable than any one of them used individually. EC has higher microbial diversity compared to benign, and histology alone explains less than 10% of variance in these data sets, and studies must account for individualistic factors such as age, BMI, and vaginal pH. And in further steps, we will identify a more robust signature for vaginal microbiome for endometrial cancer using the vaginal microbiome that will benefit screening programs. And we will do this by performing an integrative analysis by combining data from different labs using deep learning techniques. And this will allow us to account for study-specific differences. And we will also integrate the microbiome data with host genomic DNA, which will stabilize our results even further. These are my references, and I would like to thank everybody in the Uterine Health Research Lab for their support and guidance, especially my PI, Dr. Aline Talhook, my supervisory committee, and our funding agencies. Thank you for listening.
Thank you. So I would like to start with the QA part of this talk. First, I would like to give the opportunity for our educators to ask their questions.
I do have a question. Thanks, Delina. Very nice work, very interesting work, great presentation. You mentioned a number of times about the clustering technique and the denoising techniques that really gave you the advantage over other models. Can you explain those? What did you do to denoise and cluster, and why are these not used in other models?
Yeah, so the bioinformatics in this field is quite new, and we can see that early on, researchers up until 2021, they were just clustering these reads based on 97% similarity. So they would use a greedy clustering algorithm to just cluster reads based on the similarity, and then the centroid of the cluster was used for taxonomic classification further to use in the downstream analysis. But in 2022, things started shifting across the microbiome space, where they use something known as the DARA2 program to denoise these. And they use statistical algorithms to figure out what could be sequencing errors versus true biological variation in the bacterial strains. And they use these models to separate what clustering errors are from true biological evolution to only keep the true variation in these strains. And that seems to be more stable. But in our analysis, we found that denoising alone is not good enough. You still need to do clustering after you denoise these reads.
Great, thank you.
Yes, Dr. can go ahead.
Thank you so much for your presentation. It's really interesting. You did a great job in presenting. I was wondering around the sampling of the patients and then the patients who have benign. In terms of if you were to design the study to capture the sampling, what would be your ideal process?
So we're actually doing our own study in our lab with our own clinical trial. And what we're trying to do is have equal representation across all the clinical covariates that we think are confounders, enough variation in diversity, BMI, so that we can see how much BMI is how strong is BMI in actually confounding these analysis. The vaginal pH seems to be really important too. So we're trying to have our participants to measure the vaginal pH using strips and send it to us, which I think the current studies are not doing. So I think we would have an edge in our sample collection because we're trying to get a variety of different factors.
Just a quick follow-up. Do you think it changes by how advanced the endometrial cancer is versus like early versus later stage in terms of the microbiome?
Yeah, for sure, it does change. And a lot of studies have reported that as well, but we were not able to reproduce those results in our analysis. We did try it, but it seems like we cannot reproduce what authors are suggesting. And the data sets itself are so small, like our smallest is only 22. So when we do separate them by stage and grade of endometrial cancer, some of our analysis even fail because our models won't run on that small of data sets.
Thank you.
Okay, I would like to give the opportunity for the audience to ask the questions. I don't see anything in the chat. Feel free to raise the hand if you would like to ask the question. If there is none, I'd like just to ask a very small question. So the pipeline you developed, right? If somebody would like to implement their own work, what kind of limitations do they have, or what kind of things we need to keep in mind for applying your pipeline?
I think one of the biggest limitations would be the sample size. Like I showed for the Antonio cohort, which is our smallest data set, our pipeline didn't work on that one because we're using machine learning or denoising techniques to identify these errors. And we see that it kind of fails on that. So one of the limitations is that because we're employing machine learning, we need a sample size that's big enough. Yeah, I think that would be one of our biggest limitations is to
Is
have
there a number to that? How big?
Yeah, I wouldn't be able to give you a number, but with 22 samples, we didn't do quite well. So I would assume it's greater than 25 at least.
Thank you a lot. So let's now proceed to our next presenter. So the next, Jane Kim will be presenting. Jane is a master's student at the experimental medicine program under the Department of Medicine, and she's supervised by the Dr. Michael Couch. Jane will give a talk titled Clinical Decision Support System in Addiction and Concurrent Disorders, a comprehensive review and meta-analysis. So I'd like to give Jane the ability to share the screen.
Hi, sorry, can everyone hear me okay? Okay, amazing.
Oh, good.
Thank you. Good afternoon, everyone. My name is Jane Kim, and I'm a master's student in the program of experimental medicine. Today, I'll be presenting on clinical decision support systems in addiction and concurrent disorders, which is a systematic review and meta-analysis currently in the submission process by Andy Chai and other co-authors. Concurrent disorders can go by many names, like dual diagnosis, co-occurring disorder, or comorbidity. They all typically refer to the simultaneous occurrence of at least one mental and one substance use disorder in the same individual. Individuals with concurrent disorders often experience poorer physical and psychological health than do people with a single disorder. And they also receive suboptimal care due to being underdiagnosed, undertreated, and just overall a little more complex to manage as a patient. They often enter a vicious cycle between using substances as a way of coping and experiencing symptoms of mental illness. both of which lead to higher risks of marginalization, relapse, and even suicide. The complex care needs of this population can also result in higher rates of healthcare costs and utilization due to fragmented, or what we often call siloed, treatment between the mental health and addiction systems. Altogether, concurrent disorders result in challenges in clinical decision-making, with providers having to make tough treatment choices with the limited information that they have. Clinical decision support systems, or CDS systems, are intended to improve healthcare delivery by enhancing the quality and precision of clinical decisions. Traditionally, their process happens by which individual patient characteristics are fed and linked to a computerized knowledge base made up with up-to-date medical research, guidelines, and expert consensus. This results in patient-specific assessments or recommendations that are then presented back to the clinician, which they can then use to make their final informed decision. CDS tools are most often applied in places in need of personalized care, where things like medication dosing, alerts and reminders, and diagnostic support can be adjusted to individual patient cases, as well as their connection to appropriate services, especially in critical times like mental crises or overdose. CDS systems are frequently classified as knowledge-based or non-knowledge-based systems. So in knowledge-based systems, patient data are interpreted through predefined rules that generate an action or an output. Rules are often made using literature or practice or even patient-directed evidence, and are often in the form of if-then statements. CDS systems that are non-knowledge-based still require the patient data source, but their decision leverages artificial intelligence and machine learning to recognize patterns in data rather than being programmed to follow specific rules. Both of these programs are built with a communication mechanism that allows the end user to interact with the system through things like a website, application, or interface. So one example of a CDS system by Ray and others is called Embed, short for Emergency Department Initiated Buprenorphine for Opioid Use Disorder, which is quite a mouthful. This project was intended to promote the adoption of buprenorphine naloxone substitution treatment into routine emergency care through the implementation of a CDS. So in this case, when the physician launches the Embed app, they're guided through the process of choosing the best care way for each patient out of a possible 4 that they pre-made by assessing them for opioid use disorder, evaluating their withdrawal severity, and motivating patient readiness to go through treatment. Once physicians select a treatment pathway, Embed automatically generates relevant activities, including things like medication orders, prescriptions, discharge instructions, and referral. Despite their potential, comprehensive reviews focusing on the application of CDS for addictions and concurrent disorders are quite few in number. The objective of this systematic review is to then bridge this knowledge gap by investigating the impact of CDS in this field to really understand and brainstorm future therapeutic strategies for patients with concurrent disorders and their providers. The methods of this review followed the PRISMA guidelines and searched the databases Web of Science, Embase, Medline, PsycInfo, and Cinehealth with subject experts and a medical research librarian. Studies went through abstract and full text review and were included if they covered any description, evaluation, or implementation of a clinical decision support system on addiction and concurrent disorders. All study types were included except for conference proceedings, editorials, and opinion papers. And studies were excluded if they included things like fMRI imaging, natural language processing, general medicine, or primary care. And a final set of 70 papers were included in this review. So of our 70 studies, 55 were knowledge-based, 11 were non-knowledge-based, and 4 were hybrid or containing elements of both. Prior to 2017, all published studies covered knowledge-based models, and non-knowledge-based models appeared only recently from 2017 to 2022, with the most seen in 2021. All CDS models provided help with either diagnosing, monitoring, medication management, and follow-up. 29 studies of 70 targeted a specific mental health condition such as psychosis, suicide, PTSD, and depression, while others focused more on general mental health and general substance use. In our meta-analysis, effect sizes were calculated as the standardized mean difference between control and intervention groups in randomized control trials that assess CDS interventions. The average effect size for addiction-related outcomes was 0.11 based on a pool of 8 studies, which reported 21 different outcomes, such as abstinence, initiation of opiate agonist treatment, or changes in consumption. With patient and provider satisfaction or acceptance of these tools, the average effect size was higher at 0.5 based on 5 studies, reporting outcomes such as acceptance and decisional conflict. So we see that in the present state of CDS systems, we see a notable trend in publications over a 30-year period. These studies have traditionally focused on knowledge-based systems and relied on expert opinions and standardized assessments. However, there was a market shift in 2017 towards adopting non-knowledge-based and more data-driven systems. This kind of temporal transition mirrors a broader surge in data science and computational capabilities that support AI and machine learning, as we can see in conferences like these. Our results show that current CDS systems seem to have only a modest influence in addiction-related outcomes, but also come with satisfaction and endorsement from patients and providers. This may pave the way for more pronounced improvements that come with familiarity and widespread implementation in the future. With the ongoing evolution of technology, these systems will probably inevitably continue to mature in both their effectiveness and efficiency. An important consideration, I think, to remember is user-friendliness, with continued outreach and co-development with marginalized populations to really improve their accessibility and circumvent future disparities in care. For a high-quality CDSS, the tool itself isn't the sole importance, but really an encompassing ecosystem that can cater to both patients, providers, and the extended healthcare team as a whole. A CDSS working in synergy with online pharmacies and related facilities like supervised consumption sites can also ensure that there are no gaps in the treatment system and allow for patients to self-manage their own symptoms and risks. CDS tools also come with some limitations and challenges to go through. One comes from alert fatigue, which happens when the alerts produced by the CDS are considered way too overwhelming or not really important to the end users, which can lead to missed or ignored responses. Another is the existing variance in technological proficiency, which can preclude certain populations from using the systems. Particularly for knowledge-based systems, persistent upkeep of content is really critical to uphold the precision of generated information. Moreover, biases can be born from AI and black box models. So future developments will really require greater ethical considerations and transparency to ensure that there's no risk of harm to the already vulnerable patient. In conclusion, clinical decision support systems in the field of addiction and concurrent disorders have gained much attention and popularity over the last 30 years. Considering the ongoing kind of trajectory of data collection and technological advances, we believe that this demand is probably likely to continue. And in turn, hopefully utilization and efficacy of tools will also rise and lead to improved clinical outcomes. While CDS both promise in personalized care, they also require continuous monitoring and evaluation to really ensure equitable deployment. In the context of concurrent disorders specifically, they need to be part of a comprehensive approach that leverages and complements the existing care infrastructure to only better the treatment for the really patients in need. This is the end of my presentation. Thank you all so much for listening.
Thank you. We can move on to the Q&A part. First, I would like to see if the committee have any questions. Yes, no. So I would like to see. If
No, I was just sorry.
Okay.
I was thinking about it. I wanted to ask you, Jane, like how would you engage individuals who are needing these treatments, people who are living with concurrent disorders?
Mm-hmm.
Like, yeah, how would you, like, what would be the way, what methods could you use to get that user experience with them? How would you approach that?
Yeah, I think for me, what's really important is engaging with them from the beginning. So in sort of a participatory method where people can help develop these interventions with us along the way, rather than it being developed and tested with them like in the opposite direction. And so in that way, I think we can really cater to their needs and see what they're lacking and what they really want. Otherwise, we won't be able to adhere to really what their really conditions are. And if we make a lot of shows that aren't being used by this population, then it is a waste of resources and time. And so I think really engaging with them from the beginning and engaging in long-term kind of continuous ongoing evaluation where people can take turn helping us to develop and then co-develop and like monitor our changes to make sure that it really adapts to the changing needs of that population, I think is really crucial.
Thank you.
No problem.
I have kind of a similar question as Dr. Pelupu. Jane, very nice presentation. A lot of provoking thoughts went through my mind when you actually presented. Sort of in a similar vein, how it's not so much that engaging them from the start, is how to interact with them to begin with. It's I think Dr. Pelupu's question as well as mine is there are lots of these individuals who unfortunately are at places where we cannot actually reach them readily.
Yeah.
So if you exclude those individuals who are, for example, fortunate enough to come to the attention at the medical system and tertiary care centers, you can do all of that. And CDS, primarily, we're talking about tertiary care centers, I believe. Now, obviously, involving community practices would be important. But how do you interact with individuals who are outside that usual loop where most of these people may end up being?
Right. I think my presentation kind of briefly touched on how CDS tools really need to be implemented into like the existing infrastructure. So I really think we'll need to utilize things like community-based, like supervised consumption sites or local homeless shelters, and like these local kind of community services where people readily interact with providers. And I do think that's a shift from these kind of tools that were discussed here, because these are obviously in tertiary care and EDs, like you mentioned. And so I think what's really important is meeting them where they are, and going out to homeless shelters and food camps and things like that, and engaging with them. Like, I think us researchers would need to really step into their bubble and see kind of what they want in their own space, because I do think it'll be really hard to test and receive valuable information if we just wait for them to come to us. So I guess the short answer would be to utilize really local community-based resources and working with partners.
That's terrific. Thank you so much.
Thank you.
Okay, any questions from the audience? Okay, so maybe just one tiny question from me. So you mentioned biases when you were giving the challenges, right, for implementing these kind of things. So I was wondering, in your review, when you did the review of those studies, what the most common biases that being addressed in this area?
I think from us, I think if you saw the numbers from our meta-analysis, not a lot of studies really tested that their outcomes or like tested for efficacy. So I think that was one problematic area that we definitely see needs development in the future. I think the type biases that we were talking about are really common ones, like racial or ethnicity biases that exist in AI, or as well as for marginalized or homeless populations, just because we don't have a lot of data collected from them to begin with. And so I think this ties back to us needing to really go back to the actual population and hearing from their own perspectives and words what they want and what their needs are. And so, yeah, going back to local communities and meeting with the patients themselves.
Okay, thank you, Jane.
Thank you.
So let's move to our next presenter. It's Matthew Menton. Matthew is a MSc student in the experimental medicine program under the Department of Medicine and supervised by Dr. Richard Lester. His talk is titled Investigating the Experience of Physically Isolated COVID-19 Patients in Rwanda by AI-Powered Textual Analysis of their SMS Communications with the Clinicians. Actually, you probably need to share a different screen because we see your presenter view.
Oh, okay.
Yeah, perfect.
This is better? Okay. Hi, everyone. I hope you're enjoying the conference so far. My name is Matthew Menson, and I'm a master's student in the experimental medicine program here at UBC. And today I'm excited to be sharing with you some of my thesis work, which looks at investigating experiences of physically isolated COVID-19 patients in Rwanda using AI-powered textual analysis of their conversations with clinicians. So for those of you that don't know, Rwanda is a small, densely populated, low-income country in Central Eastern Africa. And despite being a low-income country, Rwanda is actually heavily praised for the success of its COVID-19 response in the literature, mainly for two reasons. Firstly, that its response has been quite effective, keeping case incidence, prevalence, and case fatality rates per capita very low throughout the COVID-19 pandemic. And secondarily, that it was very innovative. So for example, one of the key components of the pandemic response in Rwanda was the development of a home-based isolation and care program for mild cases and high-risk contacts of COVID-19 in response to health facility capacity limitations. And these patients essentially were required to isolate in their homes for the duration of their COVID-19 disease period, and supported by local community health workers, and more often a two-way texting software developed here at UBC by Dr. Richard Lester called WellTel. So WellTel is essentially a centralized communication hub that enables clinicians to easily communicate with mass populations of patients. So on the left side of the screen, we can kind of see an overall view of the workflow that WellTel enables. So clinicians can log on to a communication dashboard from any internet browser, and they can send and receive messages from this dashboard to patients who receive these text messages, phone calls or video calls as if they were texting with a friend or family member. So for example, on the right side of the screen, we can see a sample conversation from the pandemic response in Rwanda. We see the patient being checked in automatically by the WellTel platform, to which they respond with details about their day, and also difficulties with getting access to a medication that they were prescribed while in isolation at home. Ultimately, these conversations provide a good opportunity to understand the challenges and experiences faced by patients during physical isolation in Rwanda, which is really an under-investigated topic in a low-income context in general. And given that we expect infectious disease outbreaks such as COVID-19 to continue over the next century or so, understanding home isolation experiences and optimizing programs for home isolation is an important priority. In our case, however, given that we have so many conversations that were produced between clinicians and patients throughout the pandemic response in Rwanda, doing a qualitative coding analysis such as that done on in vivo is very labor intensive. Fortunately, novel computing methods, specifically natural language processing methods, can be leveraged to partially automate this process with accuracy. So our team here at the mHealth Lab, we sought out with two objectives. First, to generally investigate the experiences of individuals in physical isolation for COVID-19 infection or exposure in Rwanda. And we sought to use machine learning or natural language processing tools as a novel way to accelerate this textual analysis process. So to start off, we approach this problem with building a topic classification model in mind. Topic classification is a subdomain of natural language processing, and it's a supervised approach to machine learning or natural language processing, meaning that we build a data set that can inform the model what it wants to look for by example. So we obtained all conversations that occurred throughout the pandemic response in Rwanda from the WellTel database. We did an exploratory analysis of these conversations, finding that most conversations were fairly short, and that they occurred in different languages that were native to that region. And then we sampled the subset of all these conversations to form the basis of our training data set for our algorithm. So specifically, we took 2,791 conversations. We translated them to English so that we could label those conversations with topics of interest, which I'll expand upon on the next slide. And then after labeling those conversations that were English translated, we reverted them back to the original language in which they occurred and pre-processed them to use them for training our algorithms of interest. So as I alluded to, here's our list of topics of interest that we developed based on a review of the literature investigating secure message content analysis, as well as in partnership with the Rwanda Biomedical Center and clinicians here at Vancouver General Hospital. We ended up with a 2-tier topic list. So topics with subtopics falling under each topic. We essentially intended this topic list to be very comprehensive, covering both medical topics and social determinant of health related topics. And for example, we have the broad topic treatment with subtopics such as medication or procedures that patients may discuss with their healthcare providers. Ultimately, when we were labeling our conversations of interest, we found that our subtopics of interest were very rare. So we backed out and focused specifically on predicting topics of interest in our conversation data set. To actually go about building our models for topic classification, we use a broad approach to topic classification called the binary relevance strategy. And essentially what this means is that we take each conversation and make a model that can predict the presence of one topic at a time in such conversation. So for example, if we wanted to predict the topic symptoms, we would build a singular model that can predict that topic one at a time. And we use 2 major methodologies to go about predicting each topic. So we built traditional machine learning models that were fed feature extracted data. So essentially this means using statistical methods, and the feature extracted data is a way of numerically representing our conversations in a way that is manageable by those statistical models. We went a step further and tried to work with fine-tuning transformer architecture language models. So a lot of you are very familiar with ChatGPT. This is the architecture behind ChatGPT is ultimately the transformer model. And we tried to work with all of the models that were exposed to the Kinyarwanda language, which most of our conversations occurred in. Well, I won't get into the very specific details of how we exactly trained, validated, and tested our models. I'm happy to discuss that offline. But ultimately, we were looking to identify for each topic of interest the best performing model and apply that model to unlabeled conversations. So in the figure at the bottom of the slide here, you can see we have our human labeled conversations, which we had a team of individuals go through and label topics. Then we used those conversations to train our models and applied those models to unseen conversations, 9,000 or so. And then in the end, we ended up with essentially 3 data sets, a human labeled data set, a machine labeled data set, and then the combination of 2, which is all of our conversations of interest. Once we had our collection, our conversation data sets that were labeled with topics, we dove into actually investigating the content of those conversations. So in general, we looked at the distribution of topics and subtopics where possible, just using descriptive statistics and visualizations. And then we looked at the influence of socio-demographic characteristics of the users who are generating those conversations on the content using multivariable logistic regression models. I want to emphasize here that for the rest of the presentation, I will be presenting both duplicated investigations on the human labeled conversations as well as our complete collection of conversations, given that there was some difficulty in developing models for different topics, and that our human labeled conversations allow us to go into more detail looking at our subtopics of interest. So in terms of results, we ended up being able to classify 6 of the 9 topics of interest that we built models for. So 6 of our models were able to meet a performance F1 score cutoff of greater than 0.7. And there is a big variation in the type of classifier model that performed best at classifying each topic of interest. Well, that's a completely separate and very interesting discussion. I just wanted to bring that to your attention. In terms of conversation content, on this slide and for the rest of the slides, I've divided it into our human labeled collection of conversations on the left and our complete collection of conversations on the right. So when looking at the human labeled conversations, in the top graph, we see that medical topics of interest, so symptoms, talking about diagnostic methods, testing, prevention, healthcare logistics were the dominant topics of conversations among patients and care providers during the pandemic in Rwanda. And looking more specifically into the subtopics within those topic groups, the bottom figure, we see that when patients were talking about symptoms, very often they were actually reporting having an absence of symptoms. Or when they were talking about diagnostic methods, they were specifically talking about going to get or where to get a laboratory test for COVID-19. We were essentially...
I see you in 10 minutes, Mark.
Okay. I will quickly just finish up a few slides. So we ended up with our distribution of topics and subtopics within our conversations, and ultimately, when we're looking at content differences, we find that there was some minor differences in conversation content across socio-demographic groups, but they were very minor. So across sexes, we see that diagnostic methods were quite common. Across age groups, we see that older individuals are more likely to discuss religion and culture. Across COVID-19 status groups, cases were more likely to discuss having symptoms than contacts. And then finally, across waves, we found very significant differences about conversation content across different waves. So with that, I'd just like to summarize that we were able to successfully leverage NLP tools with some limitations. We found patients prioritize healthcare topics when discussing with healthcare providers. We also identified social and lifestyle challenges, and that socio-demographic characteristics have minor influence on content. And with that, I'd like to thank everybody for listening, and open the floor to questions if there's time.
So let's now do the round of questioning.
Thanks for your talk, Matthew. I have a question. What are some kind of downstream applications of this technology, and what do you think it could be used for in future, say, pandemic situations?
Yeah, that's a really good question. So at our lab, we're actually working on a tool that we call Conviscope, which is a real-time application of these natural language processing techniques for healthcare providers or health administrators. So essentially, you can upload any conversation data set from WellTel or any other healthcare communication data set, apply models that are pre-trained, and it will give you a visualization of the distribution of these topics in that conversation data set, to build a speedy pipeline of analyzing conversation content to inform policy making or decision making.
I have one question from the audience, from the chat. What is your advice if somebody would like to use African pre-trained LLM for a similar problem?
Yeah, so interestingly, there is a big lack of African pre-trained large language models. So for example, ChatGPT that you're all familiar with doesn't really release much of their pre-training data information. But Google or Facebook's Llama model, for example, does because it's an open source model. Still, for example, we worked with the Kinyarwanda language. Less than 0.0001% of the training data was in the Kinyarwanda language, meaning that using LLMs for African languages is still in the very early stages, and we need much more high quality training data to use those accurately.
Great, thank you. I think it's time to move to our next presenter. So thank you, Matthew. So our last presenter for today, I would like to introduce Minai Tang. She's an MD student supervised by Dr. Thalia Field, Christina Canati, and Giuseppe Garini. And her title is Named Human-Computer Interactions and Compassionate Healthcare, a Wizard of Oz study using the self-administered AI-assisted cognitive assessment. Minai, please go ahead. You can share screen.
Okay, sounds good. Can you hear me okay?
Yeah, perfect.
Okay, great. So I'll share my screen. Okay, can you see my screen? Can you see my Zoom too? Okay.
No, just the presentation.
So I'm good then. Okay, thanks everybody. I'll get started. Hi everyone, my name is Minnie. I'm a fourth year medical student. Today I'll be presenting on human-computer interactions and compassionate care using a Wizard of Oz study with a self-administered AI-assisted cognitive assessment. So the background to this study is that, as we have seen from today's presentations, previously, AI is increasingly being incorporated into healthcare and healthcare research. And for this study specifically, we're looking at AI-powered cognitive assessments. And currently, cognitive assessments are primarily done through paper and pen assessments and require trained personnel to administer, and also usually requires an in-person administration, which was, as you can imagine, a bit problematic during the pandemic and also for rural and remote populations in BC. So at our research lab, we have developed a cognitive screening assessment powered by AI. And my study specifically is not looking at how we can improve accuracy of the cognitive assessment, but rather to look at human-computer interactions and cognitive assessments as they are experienced by the users. So that's the human-computer interactions, more the implementation side of things. So what is this AI-assisted cognitive assessment? So our team is called the Canary team. We realized that speech and language are pathologically linked to Alzheimer's disease, as well as gaze. So we have developed a less than 10-minute speech and gaze assessment involving 4 short tasks. And currently using late fusion Gaussian naive Bayes, we can achieve an accuracy of 80% based on the binary classification. So it really just predicts, yes, this person has mild cognitive impairment or not. But my study today is looking more at how is this assessment experienced by patients. So I'll take you through the study design, and also later I'll show you a demonstration of the assessment because it's browser-based. So Wizard of Oz, I'm not sure if folks are familiar, but when an AI technology is not fully mature, you can use Wizard of Oz where participants believe that they're interacting with a system that is autonomous, so a fully functional AI, but in reality, it is controlled by an unseen human operator in the next room, and that's hence the wizard. So the wizard is the human behind not behind us, but the human behind the AI system. So currently we have 6 patients, six controls, 6 caregivers, and 6 healthcare providers who have done the study. They would do the assessment at home, and then afterwards we would monitor their chat logs, and also they would complete a survey and be invited into a focus group to discuss their experience. And we also, one of the research questions is also looking at design considerations for remote cognitive assessments. So the focus group worked on exploring the design considerations. So I'd like to do a quick demo of the assessment. So there are 2 pages because, as you can imagine, the wizard will need their own page. And then this is the page that participants will see. So can you all see this screen? Can I just confirm that you can see my browsers, that you
Yes,
can see the
all good.
2? Yeah, okay, great. So once you enter this, and can you
Welcome to the Canary experiment.
Okay.
My name is Al. I am your virtual assistant. First, let's calibrate your microphone. Click on Allow when browser prompts you to enable microphone. Press the Help button at any time to ask me any questions about the assessment. When you don't have questions, press Next to proceed.
So I'd like to ask it. Does anyone want to ask? Or so the L has been trained with few shot training using GPT-3 extension. So I can ask it any question. For example, what is this assessment about? So that question by the participant will be routed to the wizard page. What is the assessment about? And then this is the answer generated by GPT-3, so the AI that we have trained. And so the wizard can look at this response and be like, okay, this sentence is not complete, so we'll delete that, and then we'll send what has been generated. And this is what the participants will see.
The Canary assessment is a 10-minute cognitive screen that detects abnormal cognitive performance and early-stage neurodegeneration. Our assessment is quick, painless, easy to complete, and provides accurate results using only speech and eye movement data.
So that's sort of the gist of what the assessment is about. And then when we click next, then it will go into the 4 short tasks. So I'll go back to my original presentation. So the original Canary assessment has 4 tasks. The first is pupil calibration, a reading task, and memory recall test, and a very famous cookie theft picture description task. So I've gone through the demo. So we did a survey of people's experiences, and we have included patients who have been diagnosed with mild cognitive impairments, their caregivers, healthcare providers, and age-matched controls. And I apologize that this is sort of cut off and kind of blurry, but essentially we asked questions such as how successfully did the experiment express sensitivity, strive to understand your needs, how successfully did it listen to you and convey information in a way that's understandable to you. And interestingly, after we ran statistical analysis, and the sample size is quite small at this point, so we don't really have the statistically significant differences, but healthcare providers have rated the lowest for all of these questions, interestingly. And then I want to go into the focus groups. So because we asked about design considerations, and that's the main meat of the studies, asking people how they felt after doing the assessment. And for 3 core themes emerged. And the first is trust, technical literacy, and accessibility. So these core themes were in all 4 focus groups. So we did 4 focus groups, one with each user group, so with controls, with patients, and with healthcare providers, as well as healthcare professionals who administer these assessments, including neurologists, occupational therapists. So all of the groups have mentioned that trust, technical literacy, and accessibility need to be taken into consideration. And inversion of control target user cognitive load, standardization, and feedback mechanisms were also mentioned. So I'll show you some quotes and discuss these. So the first is inversion of control. So giving the user some control of flow and pace since it's self-administered. So one participant said that they talk to Siri all the time and feel that they're in control, so they're comfortable with the assessment. But if they're talking to a robot who's going to determine my future, because cognitive assessments are often used to determine a treatment course for someone, or to determine if they're can they drive, can they manage their own finances and things like that. So this is another piece of control that was mentioned. I guess another layer of control. So the inversion of control in terms of design, and also control in terms of how participants felt about the assessment. And then another quote by a caregiver was, I was looking for more of a personal feel, and they'd be able to give me a valuable feedback and encourage if there was something that we're stuck on. And that's more related to the feedback mechanism. As you can tell by the demo, there was like not much of there's some feedback only if you ask a question. There's no immediate sort of like spontaneous feedback by L. And another participant, a healthcare provider, actually said that impartiality of the assessor and the ability to collect data are big positives, because oftentimes cognitive assessments done by healthcare professionals can be, the inter-rater differences, reliability can be not very reliable sometimes. So that having a cognitive assessment like this will take that part of out of the equation, but also it depends on the kind of humanness of the computer. So there's pros and cons. And then a good quote by a patient was that I don't think you can replace compassion with technical expertise, and you can't replace technical expertise with compassion. There are two components, and ideally you'll have both of them. So that's these are considerations that came out of the focus groups. So in conclusion, accessibility, trust, user technical literacy are important design considerations when developing assessments, and future studies can explore the actual implementation of these clinical assessments and its design. And while AI has the potential to increase access to clinical assessments, policies and guidelines will need to be in place to facilitate trust, because I believe that just like there are lots of drug companies that are developing drugs, I think technology will become like something similar, where we'll need some guidelines and regulations to make sure that they're safe. So that is the end of my presentation. Thanks, everybody. And I'll take any questions.
Thank you. I think we have a time for 2 questions, maybe one from the educators and one from the audience.
Thank you, Minnie, for the nice presentation. Very cutting edge type of work that you're doing. Congratulations. Question about the application of Canary. It's strictly in English. Is that correct? And in BC, with the diversity in terms of language being used, what type of adaptations will you or can you make with this particular model?
Thank you. That's a great question. Currently, yes, Canary is only available in English. So, but we can definitely make modifications, especially because the AI model behind it is trained on GPT-3, which has many language modalities that we can, if we can get the assessment translated, then we could have a wider reach with the assessment. And although there will be currently the back end of the AI model that predicts cognitive assessment is only still English based, but that is something we're still working on, and we're actively recruiting participants of different races and ethnicities to increase the accuracy of the assessment in different populations.
Thank you.
Thank you.
Hi, my name is Walter. Thank you for the presentation. Brilliant app. I'm developing something similar using eye tracker, remote eye tracker. And it's nice to know that you belong to an interdisciplinary group. I'll try to reach you later on. So regarding the eye tracker, remote eye tracker, you said you were doing pupil calibration. Is that so?
Yes.
How?
So there's a master's student who has been working on, because as you know, eye tracking, we use the Tobii eye tracker, but for the remote assessments, obviously participants aren't going to have an eye tracker at home. So Anush, the master's student, worked on trying to map just webcam eye gaze with the Tobii eye tracking, so that we can use triangulation to basically approximate the eye gaze using, and then collect that data. So we with these in remote assessments, we collected the videos, and we are still working on trying to map that out with triangulation. Currently the success, I think he was able to get maybe like 85% of accuracy with the mapping, but that still obviously need to be higher, so that we can say that Canary assessment can achieve 80% accuracy even in a remote assessment. Does that make sense?
Yeah, you mean gaze tracking, or because pupil calibration, you mean finding the pupil in order to do the gaze tracking, but not measuring
Yes.
pupil dilation, which is another thing, and impossible.
No, we're not. Sorry, it's pupil calibration, not dilation. Sorry sorry, I'm on the addiction service, so
it's gaze calibration. Okay, I got it. Well, I'll definitely try to find you.
Thank you for the question.
Thank you, Nina, for your presentation. I'd like to thank everybody for participating in today's session. So the winner for this presentation will be announced during the closing remark. So please come back, and we hope to see you after a small break for the next session. Thank you, everyone.
Thank you, everyone. We'll be back at 3:30 promptly. We're on a tight time schedule, so get up, move around, and we look forward. We're going to have the Vision Cluster be introduced and have some presentations from this research cluster I'm excited about. Thank you.